It's a pleasure to be with you. The title of this talk is Pneumococcal Disease and Vaccines. There are no disclosures for this presentation. Objectives include review pneumococcal disease, review pneumococcal vaccines and ACIP recommendations, and review pneumococcal vaccine coverage and efficacy. The etiology for pneumococcal infections is a capsulated gram-positive organism called Streptococcus pneumoniae. The organism has a thick polysaccharide capsule, a virulence factor that protects the organism from phagocytosis, but also is highly immunogenic since antibodies to that polysaccharide capsule provide protection against infection. The pneumococcal vaccines available in the United States are based on developing protective antibodies against the pneumococcal organism's capsule. There are 91 capsular types expressed by pneumococcus and little, if any, cross-protection of antibodies between capsular types. The current vaccines, pneumococcal polysaccharide vaccine, PPSV23, and pneumococcal conjugate vaccines, PCV13, PCV15, and PCV20, cover the most common capsular serotypes associated with disease. This slide lists the common risk factors for pneumococcal infections, including the young, particularly those under 1 year old, the elderly, particularly those over 65 years of age, the immunosuppressed, including those with sickle cell disease, Hodgkin's disease, hypogammaglobulinemia, myeloma, chemotherapy, and functional or anatomic asplenia, alcoholism, human immunodeficiency virus infection, smoking, asthma, diabetes, chronic heart and lung disease, post-viral infections, and cerebrospinal fluid leaks. Diabetes increases the risk of invasive pneumococcal disease by threefold, and either chronic heart disease or chronic lung disease increases the risk by sixfold. Most people over 50 years old have at least one predisposing condition. Pneumococcus is passed by air droplets. It commonly colonizes the nasopharynx. Asymptomatic carriage is common. Depending on the study, from 10 to 85% of children less than 5 years old are asymptomatically colonized, compared with 4 to 45% of adults. Colonization lasts longer in children than in adults. Many experts feel that children are a major pool for transmission of the pneumococcus within a population, therefore underlining the importance of immunizing children. Some colonized individuals develop disease. Disease can be invasive, infecting body areas that are normally sterile, like the meninges and bloodstream, causing meningitis and bacteremia or sepsis. When infecting normally non-sterile sites, it's called non-invasive disease and includes otitis media, sinusitis, pneumonia, and suppurative bronchitis. These non-invasive infections can occasionally progress to invasive disease. This is a graph of invasive pneumococcal disease in the United States in 2015. It demonstrates a higher mortality in young children, particularly those under 1, and the elderly, particularly those over 65. 95% of all deaths from invasive pneumococcal disease are in adults. Pneumonia is the most common form of pneumococcal disease in adults. Annually in the United States, pneumococcus causes 900,000 infections, resulting in 400,000 hospitalizations. 90% of invasive pneumococcal disease, meningitis, and bacteremia is seen in adults. Pneumococcal meningitis and bacteremia causes up to 5,000 deaths per year. As we saw in the previous slide, 95% of all pneumococcal deaths occur in adults. With those statistics, it's amazing that only 80% of adults with risk factors and only 40% of adults 65 and older are vaccinated against pneumococcus. The next few slides discuss community-acquired pneumonia. The major etiologic agent of community-acquired pneumonia is pneumococcus. Community-acquired pneumonia is the #1 cause of morbidity and mortality due to infection in the United States. It causes 5 to 6 million cases per year, of which 75% are in the outpatient setting, but also causes 1 million hospital admissions per year. There is a 10 to 15% mortality rate when a patient is admitted to the hospital for community-acquired pneumonia, and that hasn't significantly changed since 1952, when the mortality rate from community-acquired pneumonia was 13%. The mortality rate for myocardial infarction with hospitalization is 16.8%, similar to that of community-acquired pneumonia. Studies by Kaplan and Borden demonstrated a 40 to 50% mortality rate, 24 to 30 months respectively, after community-acquired pneumonia. Treatment of community-acquired pneumonia costs about $17 billion per year. This slide is from an article in Lancet and demonstrates that pneumococcus is the most common cause of community-acquired pneumonia in the outpatient, inpatient, and intensive care clinical settings. This graph demonstrates that pneumonia is the 8th leading cause of death in the United States, greater than even breast or prostate cancer. As we saw in the previous slide, pneumococcus is the most common etiology of community-acquired pneumonia in all clinical settings, and thus a major cause of death in the United States. This is a busy slide demonstrating how to calculate an objective score for a pneumonia severity index. It's based on demographic factors like age, sex, nursing home residence, comorbid conditions like neoplasm, liver and heart failure, physical examination findings, including mental status, respiratory rate, blood pressure, and various laboratory and radiologic tests. By using these factors, an objective number can be calculated. This is a summary of an article published by Fine in 2006. A pneumonia severity index score of greater than 130 is associated with a mortality rate ranging from 24.9% for all adults with community-acquired pneumonia to 32.9% for the cohort of nursing home patients with community-acquired pneumonia. That's almost double the rate for a patient admitted with myocardial infarction. There is a misconception that hospitalization for community-acquired pneumonia is not significant and easily treated. That is not the case, and particularly depends on the underlying conditions of the patient as reflected by pneumonia severity index factors. This slide demonstrates the duration of symptoms after pneumococcal pneumonia. The main point is that symptoms don't resolve quickly. 30 days post-pneumonia, 50% still have dyspnea, 35 to 40% fatigue, and 80 to 85% pleuritic pain. Just a few comments about antibiotic resistance. Antibiotic resistance is of great concern in the United States regarding many organisms, including pneumococci. 30% of pneumococcal infections demonstrate antibiotic resistance to penicillin. This is down from 40% in 2000, likely due to vaccination of children, decreasing the pool of pneumococcal organisms in our population. Another factor may be new penicillin resistance laboratory criteria. Antibiotic resistance results in 1.2 million infections, 19,000 excess hospitalizations, and 7,000 deaths per year. This emphasizes the need for effective community antibiotic stewardship programs along with better pneumococcal vaccine coverage to help mitigate pneumococcal resistance. This slide looks at the estimated future impact of our aging population on pneumococcal pneumonia. By 2040, it's estimated that the number of hospitalizations due to pneumococcal pneumonia will double from 400,000 to 800,000 cases, with costs to treat increasing by $2 to $5 billion per year. Hopefully, we can prevent that from happening by increasing vaccine coverage of our population. There are 4 pneumococcal vaccines currently used in the United States. PCV13 Prevnar by Pfizer, PCV15 Vaxneuvance by Merck, PCV20 Prevnar 20 by Wyeth, a subsidiary of Pfizer, and PPSV23 Pneumovax by Merck. This slide shows the percent of pneumococcal organisms covered by pneumococcal vaccines that cause invasive pneumococcal disease, IPD, and community-acquired pneumonia, CAP. PCV13 covers 27 to 30% of the organisms causing IPD in those over 19 years old, and 4.6% of pneumococcal organisms causing CAP. PCV15 covers 42 to 43% of the organisms causing IPD and 6% of pneumococcal organisms causing CAP. PCV20 covers 54 to 58% of the organisms causing IPD and 7.9% of pneumococcal organisms causing CAP. PPSV23 covers 62 to 73% of the organisms causing IPD and 40% of pneumococcal organisms causing CAP in the elderly. The polysaccharide antigens in PPSV23 are T-cell independent, meaning that they directly stimulate B cells to produce antibody. T-cell dependence is necessary for the booster response. Therefore, PPSV23 revaccination does not result in a booster effect. Protein conjugate antigens, like those in PCV13, PCV15, and PCV20, are T-cell dependent and cause a release of cytokines, small signaling proteins that impact surrounding cells. Cytokines include chemokines, interferons, interleukins, lymphokines, and tumor necrosis factor. Conjugate vaccines present antigens to B cells, helping them mature, providing a longer-term immune memory and a booster effect versus PPSV23. It's important to understand that young children, like those under 2 years old, don't develop robust immunity to polysaccharide vaccines like PPSV23, but do respond well to conjugate vaccines like PCV13. This is the reason that PCV13 is used to immunize children versus PPSV23. So who should get 1 dose of PPSV23? CDC recommends that 1 dose of PPSV23 should be given to all adults 65 years or older, and those 2 through 64 years old with underlying conditions. There are several special pneumococcal vaccine recommendations for individuals with underlying conditions. Please see the link listed on this slide for those recommendations. So who should get PCV13 vaccine? CDC recommends routine administration of pneumococcal conjugate vaccine, PCV13, for all children as a series of 4 doses. 1 dose at each of these ages, 2 months, 4 months, 6 months, and 12 through 15 months. Children who miss their immunization or start the series later should still get the vaccine, but the number of doses recommended and the intervals between doses will depend on the child's age when vaccination begins. This is the CDC child immunization schedule with the PCV13 schedule outlined in red. So who should receive PCV15 and PCV20? On October 20th, 2021, the Advisory Committee on Immunization Practices, ACIP, recommended PCV15 or PCV20 for adults who had never received PCV in the past and are either aged 65 years or older or aged 19 to 64 years with underlying conditions listed on this slide. When PCV15 is used, it should be followed by a dose of PPSV23, typically greater than or equal to 1 year later. I hope these last several slides have illustrated how complicated immunization schedules and recommendations can be, underlining the importance of having a public health immunization specialist available to advise immunization programs. Let's briefly discuss the impact of PCV13 vaccination of children. Since PCV13 was introduced for children in 2010, PCV13 serotypes causing invasive pneumococcal disease in children under 5 years old plummeted for all racial groups. It seems that the racial disparity for IPD in children under 5 was eliminated with PCV13 vaccination of children. Over that same period, non-PCV13 serotypes did not decline, and the racial disparity of IPD persisted between whites and African American children under 5. Note that after PCV13 vaccinations were initiated in children in 2010, there was a marked decline in PCV13 serotypes causing IPD in adults 65 and older. The impact on the African American elderly was even more pronounced than the white group, dropping below the white incidence. This decline occurred before the 2014 ACIP recommendation to vaccinate adults 65 and older with PCV13. So this decline of IPD in older adults was not due to PCV13 vaccination of the elderly, but the result of vaccinating children. This impact on adults from immunizing children is called an indirect effect and is likely due to decreased nasopharyngeal carriage of PCV13 serotypes in children who were vaccinated. After the 2014 ACIP recommendation to vaccinate those 65 and older with PCV13, the direct effect of immunizing the elderly didn't seem to improve the IPD incidence of either group beyond what was achieved through the previous indirect effect of immunizing children. As with children, racial disparity persists for non-PCV13 serotypes in those 65 years old and older. This graph shows the IPD incidence among adults 65 years and older from 2013 to 2017. There has essentially been no significant change in incidence since 2014, when PCV13 was recommended for adults 65 and older. In other words, there were no additional direct or indirect effects on invasive pneumococcal disease incidence at the population level since 2014. Another thing to note from this graph is that non-PCV13 serotypes make up a significant number of the IPD disease burden. This graph and table show the PCV13 serotypes invasive pneumococcal disease mortality among adults 65 and older from 2013 to 2017. As demonstrated, there was no population-level impact on IPD mortality associated with PCV13 serotypes since 2014, when PCV13 was recommended for those 65 and older. Also, there was no change in the PCV13 serotype case fatality ratios percent since 2014. Let's look at some recent data regarding PCV13 serotypes in pneumococcal pneumonia. Pneumonia is not considered IPD since it is an infection of a normally non-sterile site. PCV13 serotypes cause 4 to 6% of pneumococcal pneumonia in those 65 years old and older. There has been a 31% reduction in PCV13 serotypes causing pneumonia in those 65 and older from June 2014 to May 2016. This was likely due to both the indirect effect of immunizing children with PCV13 and the direct effect of immunizing those 65 and older with PCV13. So the direct effect of immunizing the elderly doesn't seem to have much of an impact on IPD, but may positively impact pneumococcal pneumonia in that group. It's expected that the use of PCV15 and PCV20 in those 65 years and older will have a greater direct effect than PCV13 on reducing pneumococcal pneumonia in that group. Let's spend a few minutes discussing pneumococcal vaccine coverage and efficacy. Once again, this slide shows the percent of pneumococcal organisms covered by pneumococcal vaccines that cause invasive pneumococcal disease IPD and community-acquired pneumonia CAP. PCV13 covers 27 to 30% of the organisms causing IPD in those over 19 years old, and 4.6% of pneumococcal organisms causing CAP. PCV15 covers 42 to 43% of organisms causing IPD and 6.0% of pneumococcal organisms causing CAP. PCV20 covers 54 to 58% of organisms causing IPD and 7.9% of pneumococcal organisms causing CAP. PPSV23 covers 62 to 73% of the organisms causing IPD and 40% of pneumococcal organisms causing CAP in the elderly. This slide shows pneumococcal vaccine coverage rates in the U.S. for children and the elderly. The pneumococcal vaccination rates for at least 4 doses of vaccine for children 2 years and younger from 2012 to 2018 is stagnant, ranging from 81.3 to 83.8%. For those 65 years old and older, the rates have slightly increased from 68 to 70.3%. Some have postulated that the vaccine likely decreased colonization or carriage in children, therefore decreasing transmission to adults. The information in this slide doesn't seem to support that. Even though the percentages are small in both groups, there doesn't seem to be a vaccine impact on carriage or colonization. There are likely other factors involved in why PCV13 vaccination of children decreased disease in the elderly. There is need for further research. Previously, we discussed the impact of PCV13 on the prevalence of IPD serotypes. This slide demonstrates the indirect effect of vaccinating children on actual IPD rates. By vaccinating children with PCV13, there was a 40% decrease in invasive pneumococcal disease in the 18 to 49-year-old age group, 18% in 50 to 64-year-olds, and a 37% decrease in those 65 and older. As previously mentioned, vaccinating children is an important strategy to decrease invasive pneumococcal disease in adults. This slide looks at the efficacy of PPSV23 to prevent IPD and CAP. PPSV23 has a 74% efficacy to prevent meningitis and bacteremia in a meta-analysis study of the vaccine. There is somewhat contradictory results in the data depending on the study, demonstrating a range of 10 to 74% efficacy to prevent community-acquired pneumonia. CDC states that PPSV23 is most useful to prevent invasive pneumococcal disease, IPD. Let's discuss pneumococcal vaccine reactions for a few minutes. This slide just lists some common reactions for PCV13 vaccination in children. Up to about 8 out of every 10 had some fussiness and irritability. About half had some drowsiness, temporary loss of appetite, redness or tenderness at the vaccination site. 30% had local swelling, mild fever, and 5% had a fever of over 102.2 degrees Fahrenheit. PCV13 reactions in adults were generally mild, but the list includes pain, redness and swelling at the injection site, limitation of arm movement, fatigue, headache, muscle pain, joint pain, decreased appetite, vomiting, fever, chills, and rash. PPSV23 reactions include injection site pain, soreness, and tenderness, 60%, injection site swelling and induration, 20.3%, headache, 17.6%, injection site erythema, 16.4%, asthenia and fatigue, 13.2%, and myalgia, 11.9%. A contraindication for pneumococcal vaccines include a history of a severe allergic reaction to any of the vaccine components. In summary, pneumococcal disease is serious and a leading cause of morbidity and mortality. Pneumococcal vaccination can reduce vaccine-type pneumococcal disease burden. All children should be vaccinated with PCV13. Adults 65 years old and older should receive PCV20 alone or PCV15 followed by PPSV23 1 year later. Adults and children who have underlying conditions should be vaccinated with pneumococcal vaccine.